Welcome to the Syneos Health Podcast, Conversations on Commercialization. I'm Tyler Cowan, Vice President of Syneos Health. In this series, we explore the strategies and innovations shaping healthcare today and tomorrow. This episode was recorded at the Fierce Pharma Week in Philadelphia, right in the heart of the action. Let's dive in. I'm here with Mark Bard, co-founder of DHC, Digital Health Coalition. In this episode, we're tackling commercialization, HCP engagement, and what's next in pharma. Good morning, Mark. How are you?
I'm doing great, Tyler.
I wanted to ask you, Mark, given your expertise, how is marketing evolving beyond traditional HCP engagements today versus in the past?
My background is looking at industry trends. How do I step back? I've been doing this for 20 years now plus. And I think it is important to look at things in stages, whether it's physician or consumer. We'll start with physician. And you go back about 20 years ago, which is when I came in, like a lot of folks, we're at an event, this conference, that was built on a lot of this digital pharma.
I've got lots of gray hair.
Yeah, it really kicked off this rethink of how do we create and deliver content that ultimately engages. So there was a big learning experience. How do we think about these from a delivery and a channel perspective? On the physician front, the pandemic was a massive reset for every company out there. And it wasn't just for the reason it was a reset for everyone. You basically had a tested control in the perfect sense of you had no reps for a year and a half. Then also, I think what was more important is physicians really took a lot of control. They set things on their terms, because now when you look at things from an on-demand or using technology or video or detailing, they got to control when they wanted to pull that content. And so a lot of companies had to rethink, how do we do this on their terms? And I think that got a lot of people thinking about how do we use the field force effectively? How do we use these other services? And then a lot of these conversations, which started previously, but this concept of customer experience, CX, which goes into, and in many ways, there's digital, there's multi-channel marketing, there's omni-channel marketing, and in many ways, you could argue that CX is a level up from that, where now you've got a feedback loop. So we started asking physicians, what do you like? What do you dislike? What do you like about this rep? How do you want different channels? So we started to do things on their terms. What's interesting or what's changing now, I frame it through this context of what's new and what's different. What's new is there are new technologies, platforms, apps, different things that kind of came out of nowhere that I need to understand. Examples of those are things like open evidence, where we got some of these things that didn't exist maybe even 2 years ago. So now I'm like, whoa, I got to figure out this is a major channel or these types of channels that I got to figure out. We had to learn as patterns change, and they weren't specific to physicians and clinical content. Physicians are consumers.
That's what we sort of realized through this process, is that in large part we forgot that HCPs are also human beings that are consumers. And so how they consume information varies by stakeholder, varies by individual person.
Yeah, so they're on platforms like X for conference content. Sure. They're on TikTok maybe for personal reasons or something else. So they're being conditioned to use these things differently. One big one I want to get to in terms of how marketing continues to change in that extension to engagement. So one is I'm giving you the content, now I need to get you to engage with it. We've done some work over the past couple of years looking at that expectations gap, specific to, are you delivering me as a physician personalized, relevant content? Now you would look at most industries and you would say, okay, that's probably a good barometer or KPI, if you will, to say, are we doing what our audience and customer wants us to do? We still have a massive gap in this industry. And it's tough to kind of reconcile the sense of we spend billions of dollars on field forces and content, and then the physicians come back and say, depending on your specialty audience, it may only be 25, 40% of them saying, you're actually sending me something relevant. Even though we have tons of data, and we'll get into what's changing and what's cool that's happening, but we're still sending these broader segments of information. Now, what has changed very recently, we are now in this wave of new product launches are really one-to-one in the sense of we have the tools, we got the technology, the data, that for a rare disease product launch, each individual physician could realistically get their own individual content based on where they're at in the process, how they fit as a segment. And I think the other thing that gets into engagement is not new in the past year or two. We've been doing it for a little while, but next best action, which applies to marketing in general, but also from a field force perspective. We've been using the term MBA for a while. And the beauty of it is now we have all these amazing triggers that whether it's clinical or whether you've done something, you've engaged with conference content, you've engaged with someone through a video detail or something, I have so much rich information now as a rep. And historically, those kind of alerts or triggers to a field force it's noise. It's not helping me do a better job, but what you realize is the same way really relevant CX data is potentially very powerful to a rep in the sense of here's what you're doing right and wrong. And then also, this physician is engaged with this content. We're going to give you a richer picture to have a relevant conversation. I imagine whether it's a president or some executive where they get briefed before they go into a cocktail reception or a group of 10 VIPs, and they get this quick rundown on this person, this many kids, has a dog, likes this favorite team and stuff. When you get that level of rich insights about a customer and you automate it and make it relevant, it's just a better relationship. You're not walking in, putting down content, and now you wasted 3 minutes, and then the physician says, I know that.
And the HCP doesn't, in the old model, doesn't feel any level of personalization. And we've all been around long enough to see when sales representatives are basically starting their whole pitch again instead of continuing the story that they were on. Back in the pre-call planning, post-call planning that very often were not utilized correctly. At least now it's one consistent discussion, and that's what I think HCPs are expecting.
Yeah, and you get what you measure. And I think this gets back to metrics when you say, is the content and the marketing and the engagement working? One that always stuck out to me was there was a period, the iPad era, where every company made all their reps use these iPads. And one company went back and they looked and they said, wow, from the metrics perspective, these reps are just killing it in terms of their flow through the slides. Then they went back and did some actual behavioral ethnographic type research and followed. There were reps putting iPads under desk or on their lap, and they timed exactly how long they needed to stay on each slide. And you're looking like, what a massive disconnect. They're having a conversation because it's more relevant and they can tweak it in real time. They're not even showing the slides, but they know they need to stay 31 seconds on each slide.
Best detailed car in the business.
Yes. So they went, you go back and you say, okay, that's a massive disconnect. The value wasn't there based on the format or the content, and the reps were having to react. So I think we learned that way, and I think we're seeing the same thing with a lot of the feedback loop. We've done some stuff on CX with physicians, and it was interesting. There's a number of companies still out there that they're run from sales down. Well, they're run by the lawyers, really, but the sales force really has ultimate authority. And when you go and you say, do you want to turn on this feedback loop and get raw, unfiltered content from physicians about their rep experiences in detail, you still got a lot of sales leadership and field forces out there that say no.
Yeah, I'm afraid of it.
That's crazy. And their argument is, well, it may be taken out of context. How are you going to use it, right? And it's kind of the curse of CX programs. If you're capturing the data, what are you going to do with it? Are you going to judge me? And maybe it's not fair from my perspective. But I think that's where we've seen now companies that do open those feedback loops. And what happens is that golden moment, and we've seen this in a number of some of the innovative companies, now the field force says, whoa, wait a second, this is very helpful. They're not just complaining. I think we all fear that box that's on the wall that people come in and you're either going to get maybe a few really good comments, but most of them we're going to have people that are angry, right? They had a bad experience. Yeah. And I think there is that fear that if we open the floodgates of feedback from the customers, we don't know what we're going to get. But then you find is, hey, I like this what you do. I don't like this. And if you did this, I'd be really happy with our relationship.
Absolutely. We've seen a lot of activity in the recent years of the direct-to-patient space. We've been talking quite a bit during the Fierce conference we're attending here in Philadelphia around the GLP-1s that have largely driven a very different model in the pharmaceutical business where you're starting to see the creation of direct-to-consumer pieces for what was or what has been in the past a prescription-level medication. In fact, I've had a number of conversations with people who are on a GLP-1 and their physician may not even be aware. So what's your view of the current state of that market? How is that market innovating and changing against the backdrop of this much shorter, let's call it much more direct line of communication between the patients and the medications they're taking?
Yeah, we look for examples and we look for news releases or press releases from companies that say, oh, that's indicative of a trend. So clearly, even today, and you can go back, this is a couple of years ago at this point, everyone pointed to Lilly Direct. It was this first shot over the bow. And then you saw Novo and you saw other companies, Pfizer for all, and everyone kind of looked and said, is it a model? Are these tactical reactions? And then you kind of step back and you say, well, there are companies that have done direct plays in the past. They were very targeted products. They tried to loop in some telehealth. They tried to loop in easier fulfillment. I think what we've seen is it's just on a bigger scale where you say maybe it's not at a product level or a brand level. We're trying this bigger. When we were looking at this starting a couple years ago, and in some ways we heard companies refer to it as it's kind of that next evolution of DTC. You've mentioned direct-to-consumer to describe these platforms. Some call them DTC platforms, some call them DTP, direct-to-patient platforms, and the differentiation being, are we talking to a consumer or are they a patient yet? And there's some clear distinctions of what those terms mean. There's also legal differences in terms of, am I just talking to you as a general consumer and I have a very different responsibility in terms of disclosure and making sure that you understand everything that's happened. And once you're in that patient journey process, I can talk to you a little bit different. And I think what we saw is there was this big need, and what you start to hear is this term of disintermediation. And that's not a bad thing. Disintermediation can be good. Let's say you have a process. Best example is take the whole DTP conversation out and say, tell me how someone you know or someone in your family went through a process of a prescription. Took a couple hours out of my day, went to the physician's office. Sure. If I'm lucky, they send it electronically. Maybe they gave me a piece of paper because the physicians, live in
went down to the pharmacy.
Exactly. I go to the pharmacy. Now I got to figure out how much it costs. And then I got to figure out maybe there's an inventory issue, which the product categories you just mentioned, there could be an inventory issue. And then I'm starting to figure out all this. I got to connect the dots. And what we found as an industry was, how do we collapse this? And what we started to see is a lot of terms of these programs that were being rolled out to say, hey, we're going to address convenience, right? It's a pure convenience play. And that's where things like virtual care and telehealth are very important to say, I'm going to let you get and have a conversation with a clinician to move from, I think I may need this, to I need this. If appropriate, of course. And these are licensed physicians. And then the second issue is, how do I pay for this? And the other side is, what does it cost? And it's the sticker shock that we all know about, where we're going to lose, depending on category, 20, 30, 40% of people that go in and say, I thought this was going to be $10. Why is this $1,000?
Yeah.
That's that part of, now let's start to real-time benefits, all these things we've been talking about for so long. It's how do I start to make that easy? Prior authorization is a huge one, as we all know. In a lot of categories is consumers do not understand it. Physician offices are driven crazy by it.
Yeah, they're frustrated by the PAs.
And it's a lot of faxing. It's a lot of archaic processes. How do we get this information back and forth? So if I can put the PA within this process flow, and then the big one on the back end, when you do the virtual care, one person that gets left out of this process, which is a valid debate, is the pharmacist. It was a little bit of an afterthought, but you say, wait a second, you could have a direct-to-patient experience of education, diagnosis through a physician, and then we get into this process of, I don't need to necessarily have a pharmacist in the loop, I need a pharmacy. And then on the back end, you say, okay, do I own the pharmacy? Do I partner? And I think that's where there's a lot of really interesting conversations to say, yeah, I'd like to own some of it or all of it, but then now we're starting to see another concept within these programs of choice. And I think there's a couple drivers for that. One is, you want to be maybe a little bit careful in terms of how captive that physician network is. And there's certainly regulatory issues raised about how captive these physician audiences were. So what if I had options where you show up and I say, I'm going to give you 2 to 3 virtual care options. I'm going to let you choose. You're taking a choice in these different things, and they're independent, they're unbiased. Now, the reality is, when you come to my company and want to learn about my product, you're going to skew very heavily towards my product. You're not saying, oh, I want to know about everything under the sun about this category. So I think those are things we have to be realistic about. And then you start to get down to, how do you want it, Tyler? How do you want this delivered to you? Well, what we saw early on was they said, I'll send it to your home. I can get it to you in 24 to 48 hours. Mail order has always been around, but I think it was always this kind of leftover idea. And a lot of us maybe thought, oh, that's only for 60 and 90 days. It's long term. I'm going to get you a big FedEx of a bunch of pills and you don't have to deal with this for another 3 months. But now it's like, hey, great. We live in an Amazon Prime world, right? I can get this to you on time. I get it. And then speaking of things like Amazon, maybe you've got an own pharmacy. But what if I give you an option to say, you know what, you can do retail if you want to, if you prefer. Maybe you go to buy this retail pharmacy, or maybe you use Amazon Pharmacy, or you tap into one of these things that you may have a relationship with. So I think those are those big moves to say disintermediate, make it easy. And another one that we hear a lot of is these care gaps, which kind of overlays into access. But this idea of second opinions, maybe you're dealing with a primary care physician and you're not trying to displace the primary care physician, but let's be realistic. How many of us have not been in a situation where maybe the physician, for whatever reason, is saying, no, I don't think you have this, or I don't think you need this product, and you may want to just talk to a trusted person to get another opinion. And another really big one here, which is fascinating, GoodRx, which is a lot of us know when you show up to the pharmacy and you get discount cards, etc., they were using this term, patient as the payer. And this is very important because we all know that we're being asked to contribute more to our health plans, and they always seem to go up every single year. We're increasingly being conditioned to this idea of, if you want a brand of choice, you may want to pay a little bit more. There's a premium for this. You want to upgrade, or you want to have a direct relationship. And what you see is a lot of these DTP models, they were working insurance, they were doing other things, but then very quickly, a lot of these were, let's call it cash pay. I'm essentially coming in saying, the convenience, I will pay $500 for this product because the convenience of this process is so overwhelming to me, as opposed to trying to figure out insurance and deal with the pharmacy and everyone else. So that's a big shift. And then that gets into the idea of, does this apply to every product? Well, no. Let's take things like oncology or very rare infusion, women's health, men's health, dermatology.
Things deemed under a fairly broad umbrella now. There's a number of brands, and I think ED medication sort of started this concept of a lifestyle brand where it may not be an absolute medical necessity, but there's a choice. And the GLP-1 sit in that space. Some of the hair loss medications, certain things we've all seen on the TV from multiple different companies are what I think would broadly be considered a lifestyle brand. Whether that's a fair comment to call it a lifestyle brand or not, because these are real medications that have great effects, but certainly their patients are making a choice and sort of raising their hand and saying, I would like to try this medication, as opposed to the old days where, at least for me as a guy, I will admit, the only reason why I went to the HCP if I knew something was wrong and I hadn't been able to sort it out.
Yeah, and so that convenience factor coming in, then also these ideas of maybe you've had a relationship with a physician, maybe you moved cities or towns or something, and you've had a condition for a long time, and you know what product you need, and you may be in a case where, well, this may be more convenient. I need a refill or I need a new script for this thing that I have taken in the past. I know I've used it. I need a clinician to prove that and write the script. But I think that's that idea of what is this overall care system? And that's what brings up these kind of big questions about DTP as a standalone, which it is in some cases. Even with some of these big ones, they're isolated in the sense of we got to bring it back to the care ecosystem, right? And I think there's a lot of companies and brands really working now to say, how do we make that information portable, shareable? How do you bring it back into your overall care map where you have a relationship directly with the company and the brand, but does your physician know about it? Are they in the loop? Is everyone else understanding how this fits in? So those are things we need to work on.
Yeah, I wanted to double click on that just quickly as an aside from some of this, is that idea of, and I'm so glad you brought it up, Mark, how does the HCP get brought back into the loop? Because there is in the DTP model, direct-to-patient model, the real opportunity where an HCP who's been treating you for, so let's say 20 years, you're on a number of different medications, they don't even know that you're taking a certain medication because it's a DTP model. How do we ensure, or maybe we can't answer that today, but there is an element of what's the responsibility of the patient or the manufacturer to make sure that the HCPs are actually included in that decision making? Because if we start creating blind spots, I think we could potentially have a real risk.
It is a blind spot in a lot of cases today, and then you step back, and different companies have taken a little different approach. We've been looking at this for a little while, and we've gone out and we've done some research with physicians about their opinions of these programs. They're generally on board in the sense of if these programs help patients get the right medication and get a better price, physicians are generally on board with the concept. Where you see some splits as bimodal interests in these programs are, they're very on board with them for refills. If I've written the prescription for you and you want to use these platforms to continue on medication, yeah, great, this is wonderful. Where they have some concerns is the new script, the first fill, where they look and they say, that really should be an in-person physician. But we need to think about where that physician fits in. And then what we've seen is different companies take different approaches. Some went very heavy with virtual care off the bat and said, we're not really as concerned, and I wouldn't say it's a disregard for physicians, but we're not as concerned about physician perception in this category because we think that consumer demand outweighs the potential risk. There was a lot of other companies that said, no, we're looking at this, we're going to put some resources online, we're going to offer some fulfillment pharmacy options, but we are not doing virtual care. It's not against the virtual care. I think they realistically said, we need to get the positioning right. We do not want to upset high prescribers. We have relationships between the field force and these physicians. And if we come out and we don't position this right, they look at it and say, what, you got these online doctor networks and you're devaluing me. I think the companies that look and say, and there are some that say, maybe it's not first fill that we're going to roll out phase one of these virtual care offerings as really complementary to existing practices and have reps literally come in and say, hey doctor, we've got this enhanced patient support program. Sure. We can do all this cool stuff and the patient signs up, we get all their insurance, we're going to deal with, you don't like PAs, we'll deal with those for you. And let's get you in the system this way and your patients. Now, back to your other point, though, where we still don't close the loop yet, is right now when you go into the doctor and they bring up your prescription history, they're pulling that from their systems in the EHR, EMR. We got to figure out better ways to say, yeah, how do we make sure that we're getting that data then pulled in, as opposed to them having to ask you, are you getting products from anywhere else outside the system?
Right, and it's interesting because as we're talking about this, Mark, this idea of, and I can't shake this sort of thing in my mind, which is there's a real opportunity in the DTP space to have almost no quote unquote human in the loop, as we talk about when it comes to AI, and how do we make sure that the physician, being the human in this case, is kept into the loop. I really want to thank you for the time.
Yeah, thank you, Tyler. Enjoyed it.
There's clearly a lot to unpack here, and we're just getting started. In our next episode, we'll dive into how new direct-to-patient models and AI are reshaping everything from fulfillment to field strategy. Stay with us. That's a wrap on this episode of Conversations on Commercialization. Catch the rest of the series and subscribe to the Syneos Health podcast wherever you get your podcasts. If you have other topics you would like to hear from us about, send a message to podcasts@syneoshealth.com. For more future-focused, actionable life science insights, visit Syneos Health Insights Hub at insightshub.health.